Okay, great. I want to thank everybody for taking their time out of their busy days to join us today. We are in module number 2, which is going to cover kind of really just the basics of serology. And then next week, we're going to take a little deeper dive into more of the complexities of serologies. And, we designed it this way to really be able to take some time to talk about serology, since I think that's a big barrier for providers to overcome to feel more comfortable in not just screening, but managing hepatitis B cases in their practices. So it looks like we have some folks joining kind of in the morning hours, some in the evening, and some right down the middle. So it's really great to see everybody. And this is really meant to create a knowledge network and a community. Feel free to reach out to me. You have my phone number, my email. You can do that even in between the weekly sessions that we have, and really help kind of build your confidence and knowledge around hepatitis B. So in last week's module, we talked a lot about the epidemiology of hepatitis B, some of the basics around screening, how to offer and testing to your patients. We talked a little bit about the cultural differences that some of you are practicing in. So today, again, we're going to talk a little bit about just the basics of Hep B serology, particularly as it relates to screening and interpreting these tests. All right, so we're going to get started here. So as you'll recall, we did discuss a case last week in a video format. And even if you weren't available to join last week's module yet, but it is posted online, so feel free to have a look at it there. There's enough information here for you to not know about the case we presented last week. So here we have Yuen Lee, the 28-year-old woman who was born in the United States, but her parents had immigrated from Taiwan 2 years before she was born here in the United States. Yuen last week, as you saw, met with her primary care doctor to discuss family planning. And although she initially resisted hepatitis B screening, she ultimately consented to get tested with her doctor after they went through an optimized conversation about why it's important to get tested, which included really going over the consequences of untreated infection and also reviewing some of the bases of the CDC screening recommendations, which we certainly follow that, as well as the U.S. Preventative Services Task Force recommendation here in the United States. So I wanted to just start by, when you have a patient in your practice, and we touched upon this a little bit last week, what tests do you order for Yuen to screen for hepatitis B? So I think we wanted to, we'll take that as a point of discussion. Sorry, I shouldn't have advanced the slide there. So do folks want to chime in as to what screening tests they use in their practices?
Okay, hello.
Hi, patients.
Yeah, like in my practice, we use the hepatitis B profile panel.
And what's included in that profile panel, patients? And this is a
Okay,
screening test. This is the first test you do to see if somebody's infected.
okay, you do the basic surface antigen, but I work in a teaching hospital, so if somebody comes for screening, first I request for the profile panel for the person.
And what's in the profile panel? Can you tell us in more detail?
Okay, we have the surface, it's a 5 profile panel. We have the surface antigen, the surface antibody, the E antigen, the E antibody, and the core antibody with either IgM or IgG. Most of the time, if it's IgM negative, we just assume it's IgG positive.
Okay, and we're going to talk a little bit about what the distinguishing feature between IgM and IgG is in this talk today. I'd love to hear from other folks. Thanks, patients, for sharing that. Layla, Jan, folks on the West Coast, as well as other folks practicing in the African nations.
I usually screen for, oh, this is Jan. Can you
Hi,
hear me?
Jan. Yep.
Yeah. I usually get a Hep B surface antigen, and because part of the cost of labs is just drawing it, I'll get a Hep B surface antibody at the same time to screen for immunity, and a Hep core antibody to see if we need to, which will help decide if I need to vaccinate, in addition to the Hep B surface antigen.
Okay, so it sounds somewhat similar to what patient said she draws. Sorry, did I cut you off?
Yeah, no, that's okay.
Hello?
And I maybe usually, depending on the, well, 28-year-old, yeah, I'd probably just order that. I mean, I'd probably do a Hep C antibody, HIV, and the, you know, usual labs.
Okay. Other folks? I heard somebody.
Yeah, Dr. David from Northeastern Nigeria. Basically, what I do in my practice is to request for a surface antigen first before proceeding to do the complete panel that the patients have mentioned. So we usually start with the surface antigen, and then subsequently we request for the complete panel.
So use that as like an initial screening test, and if that's positive, you'll get more tests, it sounds like.
Yes, very well.
Anybody else wanted to chime in with what their practice is around this initial screening test? Okay.
Abimbola?
Oh, okay.
Yeah, yeah. Thank you so much. Yeah, I practice in a primary care clinic in Nigeria, and what usually takes place is that most of the people, when they come, we do hepatitis B surface antigen, and when that one is positive, we now go ahead and do the hepatitis. We do the full panel, hepatitis panel. We do the full panel, and also with HIV too, HIV 2, HIV 1 and 2 screening. That's
Okay.
that's what takes place in most private practices in Nigeria. Thank you.
So it's really helpful to hear in different settings what are the initial tests. We've heard folks raise the issue of cost and that influencing what you do for your initial tests. So it sounds like some folks start with a surface antigen test and use that as kind of the gateway. If that's positive, then additional tests are ordered. We've also heard some folks having an integrated panel already established in their health system to make it easier, it sounds like, for testing. And also to make what's being done a little bit more uniform. And then we've also heard about having the core antibody test as well to help distinguish whether or not there's an opportunity for vaccination. So I think all very really relevant things to be thinking about. Obviously, things get tailored to the setting in which you practice. So let's talk a little bit, about what these markers are. So Hep B surface antigen, which we abbreviate as HBsAg, is really a marker for active infection, chronic infection. And really the definition technically of chronic Hep B infection is that the surface antigen is positive for at least 6 months. In last week's session, we talked a little bit about how the age at which you acquire the infection really changes the level of risk for developing chronic infection. We also talked about the routes of transmission. So worldwide, we know that there's a lot of mother to child transmission, depending particularly in where in the world you might be residing, with certainly seeing more mother to child transmission in East Asian, Southeast Asian countries, early childhood transmission and mother to child transmission in sub-Saharan African nations, and then somewhat of a mix in other parts of the world. And then certainly here in the United States, we see a lot more transmission from unprotected sexual intercourse in adults. But again, the risk of developing chronic infection if you acquire it as an adult is a lot lower than if you're acquiring this as a child at birth. So that's the first test. So it sounds like universally every provider here thinks about that test as really kind of at least your initial screening test. And then we have anti-HBs, which is really the antibody to the hepatitis B surface antigen, what we call hepatitis B surface antibody. And that's really a marker of immunity to hepatitis B. So that's a very helpful test to tell us whether or not somebody has any form of immunity. Now, there are at least 2 different ways in which you can acquire immunity. One is through prior infection. And in those people who clear infection, so they clear their surface antigen, they will go on to develop surface antibody, but that doesn't happen in everybody, as we just discussed. And then you can also acquire immunity through vaccination, right? We have a highly effective hepatitis B vaccine. So the surface antibody, the presence of it really just denotes protection or immunity, and that's lifelong immunity. Now, the third test is the core antibody test. We typically talk about this as the IgG test. So patients, I think you mentioned that there's an option in your panel of, checking, of sending this as either the IgG, which is really kind of the total antibody test, versus the IgM. So the total, the IgG test is what we usually use to distinguish previous exposure or infection. And we'll talk a little bit about this false positive or isolated core antibody test that can be positive in somebody who if you were to check all three of these tests and what that means. So if you're ever suspecting acute hepatitis B infection, it's actually the IgM to the core antibody that's going to be positive first. So in anybody who may come in with symptoms, which we know can happen in the acute phase, but not always, right? This is largely a silent infection. But somebody who comes in with generalized kind of a viral prodrome, malaise, fatigue, some people might present even more dramatically in that acute infection stage with jaundice, abdominal pain, fevers. Checking that IgM to the core antibody is really important to know whether or not they're in the acute phase. So acute hepatitis B infection is really diagnosed, can be supplemented with the symptoms that the patient's describing in addition to this IgM core antibody if it's available in your setting. What about some of the additional serologies? So patients you talked a little bit about in your panel that you, in your hospital where you work, that some of these other tests, the first two are also can be checked. And typically these are not always done as the screening test, meaning the first line of checking whether or not somebody has infection. Now, sometimes in the right setting, it can be helpful to check these tests as well. So hepatitis E antigen is the surrogate marker, sometimes for a high viral load. So we'll talk a little bit about really in the next module, kind of when you synthesize all of these tests together and kind of describe them as patterns of infections or stages or phases of infection, okay? The other test is the antibody to really that E antigen. So we call it hepatitis B E antibody. And it typically is associated with a lower viral load. So in order to have, you typically won't ever have an E antigen and an E antibody positive, right? So you either have E antigen or some people, what we call over time, seroconvert to having E antibody positive, okay? That's typically associated with the phase of infection where the viral load comes down, which we will talk about. And then another test we haven't really gotten into yet is the hepatitis B viral load. It's a DNA test. It's a DNA PCR test. It's one way to measure the level of infection in the blood. And it's used predominantly not as a screening test, but rather as a test in somebody who has other markers for chronic infection or maybe even acute infection to figure out whether or not and how high the DNA or the virus level is in the blood. So oftentimes it's used as a secondary test after you've passed through screening to really figure out some of the additional kind of information you want in a patient who you're working up. Okay, so let's kind of go through the interpretation of these serologies. And I think this is where things can get somewhat a little bit tricky. And it can also be a little bit overwhelming to see the various different ways to interpret these basic screening serologies. I personally find that this ends up, for some providers, being somewhat of a sticking point, a deterrent towards really engaging patients around hepatitis B. You know, if I send the test, how am I gonna interpret them? So this is something you can kind of come back to. There's actually 2 slides here. We just broke it up to make it a little bit easier. So again, the screening test we usually use in the United States, I think as Jan, you mentioned here in your setting, you typically check the surface antigen test, the core antibody, and the surface antibody test. So these are the 3 tests that we recommend as screening tests, again, depending on the availability of resources and also taking into account cost. When you check these 3 tests, if all 3 of them come back negative, this means that a person is susceptible to infection, right? So they neither have evidence of chronic infection or any infection, and they don't have any evidence of immunity, right, through the presence of the surface antibody. So this is somebody who's potentially vulnerable to infection, and I really would encourage you to think about it as an opportunity to offer a highly effective hepatitis B vaccine. So that is how you interpret somebody who's negative for all three of those basic screening tests. Now, in somebody who is negative for the surface antigen test, but positive for both the core and the surface antibody test to hepatitis B, this is interpreted as being immune to having been infected to hepatitis B in the past at some point. Now, we have no test to tell us how long someone or when somebody may have been infected with hepatitis B in the past. So all this tells us is that this person has immunity. So even if they were exposed again to hepatitis B in their lifetime, they are immune. But they are immune specifically because the core antibody is positive because they've already at some point been exposed or had infection to hepatitis B. Now, this is in contrast to what we see in patients who are just hepatitis B surface antibody positive. Okay, so if you're core antibody positive and you're surface antigen negative, this means that you've been vaccinated before and you have immunity from vaccination. And so really the distinguishing feature here between immunity from infection to hepatitis B and an immunity to vaccination, this sometimes comes up as a practice examination question depending on the setting in which you're practicing. But if the core antibody is not present, this means that the person has been typically vaccinated to hepatitis B somewhere along the way in their lifetime. Okay, so that's how you distinguish the core antibody being positive in those two settings. So let's go on to the few other ways that the test can come back positive or negative, okay, to see how we would interpret these tests. So again, if your surface antigen is ever positive, it simply means that you have hepatitis B infection, okay? Again, and the way to distinguish acute infection, meaning having recently acquired it, is checking for the core antibody IgM. So anytime you see that in a test question, or you're thinking about whether or not this could be acute hepatitis B infection, the only test that's really going to really be the most helpful for trying to identify whether or not somebody's in that acute phase is the core IgM, okay? And if that is positive, that by definition means the person has acute hepatitis B infection. Now, how does this differ from chronic infection? Well, your core IgM, if you were to check it, again, and it's not always used as a screening test, as we talked about, is negative. Okay, so if the core IgM is positive, it really denotes acute hep B infection. Again, you'll see that still the surface antigen and the core antibody are typically positive in somebody who's chronically infected. Now let's talk a little bit about this last scenario, because this is, I think, where things can get a little confusing for folks. So let's say your surface antigen comes back negative, your core antibody comes back positive, but your surface antibody came back negative. So we just described various scenarios in which if your core antibody is positive, either your surface antigen or your surface antibody is positive. So we're talking about a very different test result here. Here we're only seeing isolated core antibody coming back positive. So there are a few different interpretations for these tests. And this includes either resolved infection. So you may have had surface antigen that was positive, but you lost it, but you never developed the protective surface antibody. But that means that you had it in the past if you had core antibody that's positive, right? You can sometimes see a false positive, so meaning that you've really never been exposed to hepatitis B, but this is a falsely positive test. And I'll say patients, this is where checking the E antigen and the E antibody test can sometimes be helpful to distinguish whether or not it's a false positive, in which case the E antibody and the E antigen is typically negative. versus were they really ever exposed or infected, and you might see that the E antibody is also positive if you were to check those additional tests. And then you can also see this in a couple of other scenarios. One in which somebody has actually chronic infection. So it's not quite what we think about when we talk about occult infection, but where their surface antigen is not positive, but if I were to actually check a Hep B DNA level, they would be making a small amount of virus. And if they're not making it in the blood, sometimes we may even see it like histopathologically if we were to be doing a biopsy, if we were to do the stains for Hep B infection. And then this sometimes can be seen in the pattern of resolving acute infection. So somebody who, again, is acutely infected and is kind of transitioning away, their IgM, if you were to check it, would not be positive, but their total IgG is positive, which is what we're checking here. And they're going on, they haven't quite developed the immunity that we see with surface antibody production. Okay, so this is a scenario which you are not going to see very commonly, but I think it's one to be aware of, and that there are different ways to interpret this test result. The most common thing is going to be either resolved infection or a false positive, but it's important to know about this concept of having kind of low-level chronic infection, so doing some additional tests, such as the Hep B DNA test, the viral load, to see if, make sure they don't have low-level chronic infection, as well as maybe checking the E antigen and E antibody test to see if whether or not they really were infected sometime in the past. And again, if it's resolving acute infection, if you were to repeat some of these serologies, typically you would see the surface antibody become positive at some point in the coming months. All right, so I think this might be a place we circle back to at the end of the discussion in case folks have questions. We'd be happy to discuss it in more detail if needed. So here are the lab tests, again, just to summarize, that we typically think about when we're screening somebody for Hep B infection. We talked about getting the surface antigen, core antibody, and surface antibody. Now, these are the tests we typically would get for somebody who we've now established as surface hepatitis B surface antigen positive. So these are the additional tests you want to get. So you want to make sure, again, that their surface antigen is positive, and that should trigger getting your hepatitis B E antigen as well as E antibody test sent, as well as your Hep B DNA, PCR, or viral load virus level assessment done. The additional tests that you usually check for patients who have chronic Hep B infection to supplement, and this really will kind of lead into the module for next week, include your liver tests. So typically at least an ALT test is what is recommended to be checked. And then additional markers that might help you determine fibrosis level. So there are a number of different non-invasive ways we can measure fibrosis level. So there's things called a FIB-4 score, an OPRI score. We have other non-invasive tests such as transient elastography, depending on the setting in which you practice. These more sophisticated, expensive tests are not usually available in primary care-based settings, but using age, ALT, and some other markers, we can usually calculate non-invasive scores for fibrosis in any patient. And then in select patients, you may consider actually a liver biopsy. We do less of those, I would say, today with some of these more non-invasive markers being developed. So here are the clinical phases that we think about. You know, I think we showed you at least one slide in our first module on this, and we're going to kind of keep coming back to this. So, so you see here, in the early phase, you typically have, again, the x-axis here is time in years. And what you see are various test results. So the E antigen tends to be positive in the early years of infection. And in parts of the world where people acquire this at a young age, it typically coincides with being a younger age, but this is really time in years on the x-axis. This E antigen phase can be associated with a high hepatitis B DNA level and a normal ALT. And here you have kind of some of the descriptors that we use for the various phase. So this is what we would call really the immune tolerant phase. And then, sorry, what you see, I'm going to show you kind of, this is the old terminology, and we're going to go to some of the newer terminology on the next slide. over time, what happens of having this infection on the order of 20 plus years, over time, this Hep B DNA level starts to cycle slowly downward, okay? And it's not always a linear trend where if we were to check it, you know, very regularly on somebody, it would come down. It might actually bounce around a little bit, so it's important to understand that. And then over time, this time period of having it for more than 10 plus years, you might see the ALT rise as you clear your E antigen and you develop E antibody over time. Okay, so this kind of gives you the natural clinical phases of this infection having it over time. So you start out with E antigen typically that's positive, a high DNA level, a virus level, and a low ALT. This is, from the old terminology, what we call immune tolerant. And then over time, what you see is the ALT goes up at a period and then comes back down, and the Hep B DNA virus level typically comes down as you develop E antibody. And then these phases are characterized as what we call immune clearance, because you're clearing the E antigen part of the virus and transitioning into the chronic hepatitis really phase. And the old terminology here was inactive carrier. Once you're E antibody positive and you have a low hepatitis B DNA level and low ALT. This was a very problematic term, and we've now, I'll show you on the next slide how we've moved away from it very recently, because it was like, what does it mean to be an inactive carrier? That almost seemed like it was contradicting itself. And then the terminology for reactivation, E antigen, we've now kind of gone over into this chronic hepatitis characterization, okay? So this is kind of the updated nomenclature that we use. So you have the original or older terminology on top, and as it relates to the same phases which we see with respect to the serology results. So again, in this early phase of infection, in the first, you know, several years, decade, their patients are usually E antigen positive, have a higher Hep B DNA level, a lower ALT level. So we used to call this the immune tolerant phase, which wasn't very descriptive. And now we call it, in the updated terminology, a normal or minimal hepatitis phase. In the subsequent modules, we're going to talk about how these various phases relate to when you initiate treatment. Okay, so that's going to be coming up. I'm trying to take this, we're trying to take this in baby steps so that it's not laid out in a way that's overwhelming to consume. And then this immune clearance phase is now called chronic hepatitis. So this is the phase in which the E antigen might be waning, the Hep B DNA level might be kind of oscillating or coming downward trend, and the ALT might go up. And then this is followed by the normal or inactive hepatitis phase. And then what you worry about over time in these chronic hepatitis phases is that you develop fibrosis progression. We talked a little bit about in the last module, the risk of cirrhosis and liver cancer risk being independent of developing progressive fibrosis, and really Hep B DNA level over time being elevated can be a predictor for both of these things. So again, old terminology, which wasn't very descriptive and was somewhat confusing, has been replaced by this newer terminology. All right, so I think we wanted to kind of circle back to the case we talked a little bit about in the beginning. So wanted to open it up. So we had a 28-year-old who was born in the United States, whose parents were born in Taiwan. The screening, initially in the conversation, the patient didn't want to have hepatitis B testing. And again, if you watch module 1 and watch the video, you'll see how the initial discussion was then optimized and the provider was able to engage the patient around Hep B testing. So what are the tests folks would want to get for that patient as initial screening test? You can open it up to discussion here. How about we have some of the folks who maybe haven't spoken up yet?
Okay.
Hello.
Hi.
Hi. So I would get a core and surface antibody and then a surface antigen to start, and then from there proceed if she could have chronic infection from vertical transmission.
Great. And so let's talk through the scenario a little further. So let's say you start off with those 3 tests, and we can open it up to everybody. Let's say the surface antigen, and the core antibody both come back positive. What are folks going to want to do next?
Well, yeah, Dr. David talking. I will. I would want to further do the E antigen and the E antibody check for her, and then subsequently the HBV DNA 2 would need to be done for the patient.
Great. Yeah, so you know that serology interpretation, right, would be somebody with chronic infection, right? Their surface antibody is negative, their surface antigen is positive, and their core antibody is positive. So that person, has infection with hepatitis B. So you want to do some additional tests. Those additional tests, Dr. David, as you just described, it should include drawing a hepatitis B E antigen, a hepatitis B E antibody, and a hep B DNA PCR or virus level. Any additional tests that folks might want to get?
I would get an ALT, AST, and a CMP panel in addition to platelets to start.
Right, and CMP here stands for Comprehensive Metabolic Panel for folks who are practicing in different settings. So that's typically a combination of what we call our liver enzyme test or liver hepatic panel, which also includes some additional liver tests, as well as our basic metabolic panel. So you'll also get a creatinine and some other basic metabolic tests.
Great. I think I'm getting a little notification that patients, do you have your hand raised? Patients who might be having some audio issues here.
Okay.
So we'll look into that. Sorry, Ponni.
No, that's okay. Would love to hear. Any other thoughts? Any questions? Just kind of went through a lot of information there. So in the past, I'll tell you what some folks have done is we can send this as kind of one table, the serologies 1 and 2, and you can make like a little card if you need to and take a picture on your phone or keep it in your pocket if it's at all helpful for folks who are just starting out, learning how to do testing. Okay, so I wanted to talk a little bit about, if there aren't any questions right now, I would love to turn to the case that patients submitted.
Yeah. So in addition to that,
Patients, I think we're getting a little bit of audio lag, unless that's just me. Was everybody else able to hear patients?
I also heard
but not very well.
Yeah, patients. Yeah. It may help if you disconnect and try to reconnect to the meeting. I assume it's probably an internet or a connectivity issue because we've lost you on video as well. So maybe if you wouldn't mind exiting and then rejoining the link, that might help. Also,
Kate, do you want to email her also, maybe in case she's booted? She's not in the meeting. She may not have heard that.
Absolutely, I will. I'll send her a message right now. Afasulahi, was there something that you wanted to mention at all? I saw a raised hand, but
I see patients back on too.
All right. We'll give, this is always the fun of a 15-person webcast with broadband. We have little technical issues. Let's try it again. Patients, any luck on your end with connectivity?
Hello?
Okay, well maybe this might actually be the best time. Oh, yes, Afasulahi. All right, well, as we hopefully give the broadband and the bandwidth a little bit of time to reset, there are actually just 2 brief polls that I want to launch sort of at the end of the presentation now before we get into a bit more of the case study discussion and sort of the back and forth. So similar to those pre-test questions, you'll see 2 polls that are going to appear on your Zoom platform. The first one should be launching now. It's a question that you received at the beginning of the lecture as well, which is, how confident are you in interpreting HBV serology? So you may have a different answer than you did at the beginning of the lecture based on how you feel with all the information you've received. So I'll leave that up for about 10 more seconds. All right, I'll leave it up for just a few more. All right, great. And then one final question that we're going to poll today, you also saw it at the beginning of the lecture, is how much do you agree with the following statement? I correctly distinguish between HBV immune, protected, or infected status based on serology. Never, rarely, sometimes, often, or always. And again, taking into account what you may have learned or how you may feel differently about this level of comfort based on the lecture that we just received. So I'll leave that up for another 10 to 15 seconds. And then hopefully we'll have a little bit easier time with the case presentation. All right, great. So I've got all that. Thank you all for your answers. Patients, any luck on your end if you try to unmute there? Yeah, I'm getting annoyingly, I'm getting a couple different messages about lag and glitches.
So David, we're done with the practice polls, right? So why don't I, sorry, Cade, sorry.
No problem. Yeah, we're all done with the polls now.
Okay, so why don't I go ahead and read from the case that
Sounds
patients submitted, and we can also, if she's able to join with the audio and video working, have her, you know, chime in as well. We can also discuss it next week if it's not working for this week. But let me go ahead and read what patients submitted. So, and I thank you again. We're going to ask you guys for each module to try to think of a case for us to kind of walk through. Patients, I see your audio or your videos up. Audio still may not be working. So, so this is a patient who was born in 1975 in Nigeria. And the patient has a body mass index of 25.5, lists the total number of people in their household as 6, and Hep B status of other household members, 1 with known hepatitis B, 4 who are vaccinated against hepatitis B, 1 whose hepatitis B status is unknown or the person is not vaccinated. The year of diagnosis of hepatitis B was 2012. Looks like this patient has been started on hepatitis B treatment with tenofovir. And let me go through this. So the current medications include tenofovir, as well as the patient is taking amlodipine 10 milligrams, so may have some other medical problems, including hypertension. The patient's been on treatment since July of 2016 with tenofovir. The patient also occasionally takes traditional medications for body aches. And if you look at the serology testing results, and you know what I might actually do here? Give me 1 second to make this easier for folks to follow with me.
Oh, great. Yeah, if a screen share is possible, that might be best.
Let me show the screen share, because I could rattle these off, but it may not make a whole lot of sense. So give me 1 second. Let's see if this works. Here we go. Can you guys see my screen and the Word document?
Yeah.
Okay, sorry. So again, born in 1975, so a 44-year-old person of African origin, born in Nigeria. 6 household members that the person lives with, 1 who is hepatitis B positive, 4 who have been vaccinated, 1 whose status is, or no one whose status is unknown or unaccounted for. The patient is currently on hepatitis B treatment, was diagnosed in 2012. They have a family history, it looks like, of liver cancer or cirrhosis, and they're on tenofovir as well as amlodipine. And actually, I just noticed they're on another medicine, Livolin Forte. I'd have to look that one up to see what that translates to here. Occasionally takes traditional medications. These are the serology test results. They're surface antigen positive. It looks like they are e antigen negative. and it looks like they are core antibody positive as well as E antibody positive. Looks like they've been screened for hepatitis C, and that came back negative, as well as, let's see, any other test results here? I think I've gone through most of them, and their Hep B DNA, sorry, was 986,000. Okay, so E antibody positive, core antibody positive, surface antigen positive, E antigen negative, and their Hep B viral load is known, they're Hep C negative. All right, so we also have some additional tests that include the liver panel test, as well as a complete blood count. So it looks like they have a normal white count, hemoglobin's 13, platelets are normal. And why are platelets important? We talked a little bit about last week. Start thinking about that. We'll come back to it in a second. So normal level of platelets, creatinine looks normal as well. Glucose, not sure if this is fasting, but is 138. If you look at their ALT level, it's 24. AST 16, the gamma GT is 19, alk phos is 98. We know the total bili is 2, and the PT is 16, and the INR is 1.4. The patient had an ultrasound of the abdomen in July of 2015, and this patient also had transient elastography, and the stiffness score came back as 7.4. Okay, so there's no primary question entered about this case, but I think there are different things that we can discuss. So what additional questions might people have for somebody managing this case? So obviously this patient has chronic infection, is taking tenofovir, and these are the test results. It looks like prior to starting tenofovir, since the tenofovir was started in 2016. So it looks like they were E antibody positive, but their viral load was elevated. I think some of the things that stand out to me is that the family history, right? So this person reported a family history of somebody having liver cancer or cirrhosis. So if we start from the beginning here, they live with a number of additional people, so you want to know how many household contacts the person has, and all of the household contacts, remember we talked about this last week in module 1, should be screened for hepatitis B, right, as a first test. Once you know one family member has infection, you want to test the other people or offer testing. Let's see here, I think there's something coming through in the chat maybe. Okay, so someone just chimed in that Livolin Forte contains phosphatidylcholine, which maintains the structural and functional integrity of the cell membrane, and it replenishes phosphatidylcholine, helps in the regeneration of liver cells in the case of liver damage. Sounds somewhat familiar to ursodiol, would be the medication that we use, or the equivalent in the United States, or ursoforte. So it often is given for patients with various liver diseases. There's not a lot of literature that supports its use in viral hepatitis, to be honest. It's actually mostly been studied here in the United States and elsewhere in patients with other liver conditions such as primary biliary cirrhosis or primary sclerosing cholangitis. And in those scenarios in which you have a very cholestatic liver disease, if the alkaline phosphatase gets better on ursodiol or ursoforte or this type of medicine, that can improve a patient's chances of not developing as much fibrosis over time. But again, it is used kind of just broadly in patients with liver disease, although the science as to how it's helpful is not as strong in some of those non-cholestatic liver disease like viral hepatitis. So it's important to know the number of people in the household, what their hepatitis B status is. So we recommend everybody get screened for hepatitis B. It looks like one other person has known infection with Hep B, and the other 4 have been vaccinated, which is also very important. I don't think we know anything about the other member of the family who has hepatitis B, whether or not they're on treatment. And why is this important to know whether or not other people, the status of their hepatitis B? whether or not they're infected or not. Why is that important? Folks want to chime in? So we know that, again, a common way hepatitis B is transmitted is not just mother to child, but in early childhood and through close household contacts. So you want to know if there are opportunities for prevention. So it's recommended we test everybody else in the household, and then in those whose all their serologies, screening serologies come back negative, we would offer them a vaccine. So in this case, it looks like this person has 4 other household members who have already been vaccinated. Patients, are you able to hear us?
Yeah, I can. I can.
Oh, and your audio is working. Great. So we were just talking about this great case that you submitted, and I was kind of trying to walk through it step by step.
Okay.
I guess one question for you on this form. So it sounds like a 44-year-old gentleman born in Nigeria who is not overweight but has chronic Hep B infection. They have 6 household members. It looks like 1 household member
Had hepatitis B.
has hepatitis B, 4 have been vaccinated. Go ahead.
Yeah, and 4 of them were vaccinated, and basically that was one of the child who was infected.
So this one that was infected, the other household member that's infected is a child?
Yeah, about 10 years.
Okay.
And that was the oldest of the children.
So one question I had, it says this patient was diagnosed in 2012. Do you know anything around how they were diagnosed?
No, there's a routine thing they do in Nigeria here. Maybe when they have outreaches, people just avail themselves and have screening done. But sometimes even when they're positive, they don't come for follow-up visits. So since 2012, we never saw him. We saw him for the first time in 2015. And then taking history, we asked. He said he had tested positive in 2012. And then that was the first time he tested positive. And subsequently after that, he had it checked. But he was getting worried at this time when they lost a family member to liver cancer. And that was the reason why he presented.
So that often really motivates people to come forward to, be further evaluated, having the family history. Do you know who the family member was who died of liver cancer or liver cirrhosis?
Yes, he was the father's brother.
The patient's father's brother, so the patient's uncle?
Yes, yes.
Okay, and they died of liver cancer?
Yes.
Okay.
Complications. He described it. Most of the time, they're not able to tell you, but we just query it. But they said it was actually a liver disease, cirrhosis. He had swollen abdominal swelling, weight loss, and then he had an episode of hematemesis. So we queried probably liver cirrhosis with malignant transformation. It was queried.
Wow.
Yeah.
So a lot of times we don't have the records, right? So what we're asking patients to do is to try to think about the circumstances which they can recall. So asking them about, do they have a big belly? Were they told they had fluid in their belly or ascites? Were they jaundiced, deeply jaundiced when they passed? So these are all important things to try to tease out if they're reporting a family history.
Yeah.
So, I think we're at our 1 o'clock time mark, and there's a lot in this case. So I wanted to at least start by going through like the screening serologies to match what we did today. I would love to come back to this case next week to then talk about the treatment part, because I think it'll match very nicely with the presentation we'll have. So I think we talked a little bit about screening today using this case, but we'll talk a little bit more about management next week using the same case, if that's okay with you, patients.
It's fine. There's no problem. That's
okay.
Fine.
Did anybody else have any other questions about this case before we wrap up for today? And again, we'll use this as a discussion point for next week as well. Are there any other questions in general about what we covered? Like I said, we're going to take a deeper dive into those different phases and management starting next week, but wanted to start off with a small bite with interpretation of the basic serologies today. Okay, if nobody else has any other questions, then I think we will wrap up today's session. I think David, Dr. David, did you raise your hand?
Yes, I did. Yeah, I was going to mention that maybe Dr. Patient should also tell us more about the ultrasound scan finding of the patient. Because the ultrasound scan result was just echogenicity of the liver, something like that. We can get more information on the ultrasound scan.
So Patience, was there anything else that you you could add regarding this? This sounds like the pre-treatment ultrasound scan, correct? Ultrasound?
Yeah, it was just an echogenic liver. The borders were regular. There were no nodules in the liver. There was no spleen, and there was no ascites.
Okay, so those are very helpful things to try to tease out whether or not this person had more advanced liver disease, which I think we're going to talk in more detail next week, versus an earlier stage of liver disease. So really, you know, kind of the next step, which we're going to talk about in the coming modules, is how do you synthesize all of this information to make it very useful to see whether or not this person has more advanced liver disease or not as advanced. And this also can help with kind of how we decide who needs to start treatment for hepatitis B and who maybe can wait. So I think there's a lot of really helpful information here that we'll kind of talk about in a little bit more detail next week. That's okay with folks. Does that sound good, Dr. David?
Yeah, that's fine.
Yeah, very well.
Okay, great.
Great. Well, thank you all very much to our learners. Thank you for joining and taking some time out of your busy schedule to be here. We really do appreciate it. And thank you to Dr. Perumalswami for leading us through what is definitely a complicated but really interesting topic of serology and hepatitis B. Just a few things I'd like to point out. In the chat, you should now see a link to a post-test and evaluation form. So we greatly encourage you to do that. It helps us sort of gauge certain elements of the learning, how the program's actually going. If you don't have a chance to do it today, we will also be sending the link in the follow-up email that you should expect from us tomorrow. Related to that, we will send today's slide deck as well as some information about when the next module will be. It will be the same time next Tuesday at 12 p.m. Eastern time, or whatever that means for your respective time zone, but we'll be sending a link to that. And my colleague Rachel, who you all met today, will be sending official calendar invitation, so you can actually have it in your calendar as well. And with that being said, I believe we are ready to wrap up Serology Part 1. We very much look forward to seeing you next week, and thank you all for your time today. It was a great lecture, and thank you, Dr. Perumalswami, for leading us through that.
Thank you all. Until next week.
Thank you so much.
Thank you.
Have a great day, everybody.